Hi everyone, our subject today is lymphadenopathy in pediatrics. Basics. Lymphadenopathy is enlargement of lymph nodes which may be physiologic or pathologic. Normal lymph node size vary depending upon the lymph node region and age of the child. Cervical and axillary region up to 1 cm, inguinal region up to 1.5 cm, epitrochlear region up to 0.5 cm. Lymphadenopathy can be regional, localized, or generalized. Generalized, which means enlargement of two or more non-contagious lymph node region. Any palpable supraclavicular and popliteal lymph node is considered abnormal. History. Preceding symptom, upper respiratory tract symptom preceding cervical lymphadenopathy. Localizing sign or symptom, stomatitis may be associated with the submandibular lymphadenopathy. Duration, acute less than 3 weeks, subacute 3 to 6 weeks, chronic more than 6 weeks. Constitutional or associated symptom like fever, weight loss or night sweating, arthralgia, rash, bruising, petechiae, recent illness or trauma. Exposure like cat exposure in cat scratch disease, uncooked meat in toxoplasmosis, tick bite in Lyme disease, medication like phenytoin or INH, steroid or other treatment, travel or residence in an endemic area should raise suspicion for tuberculosis and Lyme disease. History of recurrent, deep-seated or opportunistic infection, family history of primary immune deficiency disease. Rate of growth, immunization status, diphtheria, measles, mumps, rubella, sick contact, dietary history, unprotected sexual activity. Supraclavicular node seen with malignancy. Right side supraclavicular node is associated with the mediastinal malignancy. Physical examination. A comprehensive physical examination should be performed to look for signs of local or systemic disease such as scalp infection, conjunctivitis, pharyngitis, dental infection, skin lesion, hepatosplenomegaly, or joint swelling. Assessment of the lymph node. Location, number, size, consistency, mobility, tenderness, and color of the overlying skin. Regional lymphadenopathy suggests local cause and should prompt search for pathology in the area of the node drainage. Generalized lymphadenopathy, a manifestation of systemic disease. Reactive lymph node, soft, small, discrete, mobile, and minimally or non-tender. They are often referred to as shorty. Infected lymph node, isolated, tender, overlying skin, warm, and erythematous. May be fluctuant, less mobile, and discrete than reactive lymph node. Malignant lymph node, hard, fixed, or matted to the underlying structure, usually non-tender. Lymphoma, firm and rubbery nodes. Etiology, it may be due to reactive lymphadenopathy, a common and normal function of lymph node characterized by hyperplasia in response to antigenic stimuli. Lymphadenitis, an inflammatory response to bacteria or their products, accompanied by erythema, warmth, and tenderness. Malignancy by primary origin in the node or secondary to metastasis. Rare lipid storage disorder. How to approach to the patient with lymphadenopathy after performing history and physical examination. The location, either localized or generalized. If it is localized, a small non-tender node associated with the upper respiratory tract infection, skin or dental infection. This is reactive adenopathy. If it is warm, tender node with or without fever, with or without erythema, this is adenitis. If it is less than 7 days, this is acute onset, like in pharyngitis. A patient need test for group A streptococci, rapid antigen detection test, throat culture, CBC, monospot test, Epstein-Barr virus titer, viral polymerase chain reaction. Differential diagnosis: Group A beta hemolytic streptococci, adenovirus, Epstein-Barr virus, cytomegalovirus, herpes simplex virus 1 and 6, and enterovirus. Or it is maybe an acute state, maybe suppurative or abscess, unilateral. Patient need CBC, blood culture, incision and drainage, aspiration. Differential diagnosis: Staphylococcus aureus, group A beta hemolytic, anaerobics, Pasteurella multilocide, Yersinia pestis, lymphogranuloma viridium, syphilis, Kawasaki disease. If it is adenitis, but it is more than 1 week, 1 to 3 weeks, this is subacute chronic onset. Patient need complete blood count, ESR, C-reactive protein, PPD test, chest X-ray for group A, test for group A streptococci, PCR, serology for Epstein-Barr virus, cytomegalovirus, toxoplasmosis, Bartonella, Hensel, HIV, echocardiography. Differential diagnosis: Epstein-Barr virus, cytomegalovirus, toxoplasmosis, mycobacterium tuberculosis, atypical mycobacterium, S. aureus, group A beta hemolytic, streptococci, cat scratch disease, herpes simplex, enterovirus, Kawasaki disease. If it is localized but it is chronic, more than 4 weeks, patient, you should look for sign and symptom of possible malignancy, which is red flag. If it is supraclavicular, as we mentioned, if it is fixed, matted, progressive, paleness, enlargement, sign of symptom of airway obstruction, prolonged constitutional symptoms like fever, night sweating, weight loss. If patient does not have this red flag, as we mentioned in subacute or chronic approach, the same approach. If it is yes, one of these is present or more than of one present, patient need complete blood count, C-reactive protein, ESR, LDH, alkaline phosphatase, uric acid, imaging, chest X-ray, ultrasound, CT. Consider referral for biopsy, bone marrow aspiration study. Differential diagnosis: Hodgkin disease, non-Hodgkin lymphoma, leukemia, neuroblastoma, rhabdomyosarcoma, and thyroid cancer. If it is generalized lymphadenopathy, as we mentioned previously, is there any sign or symptom suggestive of malignancy, any red flag? If it is yes, the same approach as we mentioned previously. If it is generalized and not associated with any of the red flag, either drug reaction, history of a drug, medication, phenytoin, phenobarbital, carbamazepine, INH, aspirin, penicillin, tetracycline, cephalosporin, sulfonamide, steroids, and other. If there is no drug history, is there systemic symptom like rash, fever, hepatosplenomegaly, arthritis, arthralgia? Patient need complete blood count, C-reactive protein, ESR, ANA, VDRL, RPR, PPD, chest X-ray, viral serology, HIV test, Lyme titer, cytomegalovirus, Epstein-Barr virus titer or PCR, toxoplasma titer, imaging, ultrasound, CT, biopsy. Differential diagnosis: either infection, viral like Epstein-Barr virus, cytomegalovirus, herpes simplex virus 6, parvovirus, B19, HIV, rubella, human herpes virus 6, bacterial infection, syphilis, Lyme disease, salmonella, brucella, disseminated tuberculosis, other infection, toxocara, histoplasmosis, malaria, toxoplasmosis, sinus histocytosis, immunologic, serum sickness, SLE, autoimmune lymphoproliferative disease, autoimmune hemolytic anemia, storage disease, Gaucher, Niemann-Pick, sarcoidosis. Recommended investigation: basic investigation for every patient. First line, chest X-ray, investigation and help in case of TB or lymphoma. Ultrasound of the neck is useful for any lump. Complete blood count for leukocytosis, fever, bacterial infection. Atypical lymphocytosis for mononucleosis. Liver function test abnormal in any viral infection, Epstein, cytomegalo, and any other virus. Epstein-Barr virus serology panel test or IgG for Epstein-Barr virus. Tuberculin skin test for suspected TB adenitis. Serum antibody study for Epstein-Barr virus, cytomegalo, HIV, or Bartonella cat scratch fever. Needle aspiration for a gram stain and culture in suspected malignancy. Advanced investigation. If any of the red flags we mentioned previously are present, malignancy is suspected and necessary evaluation should be done. This may include examination of complete blood count for anemia, thrombocytopenia, leukopenia, or leukocytosis, and for blast cell. Because of the tumor burden or bone involvement, there may be an elevation of lactic dehydrogenase, alkaline phosphatase, and uric acid level. A CT scan may be also considered. A close clinical follow-up should be done to watch for progression of symptoms. If cancer is suspected, a referral should be made to the appropriate specialist for biopsy or for bone marrow study. Top tips. Lymph node act as filter between lymphatics and the hematological circulation. They contain immunological cells including macrophage, B cell, and T cell. The most common neck lump is reactive lymphadenopathy, usually caused by viral infection. The condition is benign, but lymph node may remain as harmless palpable lumps for months or years. Parents usually fear the possibility of cancer. It is important to reassure them. Generalized lymphadenopathy suggests either systemic infection, AIDS, mononucleosis, toxoplasmosis, autoimmune like JIA, or malignancy like leukemia. JIA often present with the generalized lymphadenopathy seen mostly in systemic form like Steller's disease in association with fever, rash, and hepatosplenomegaly. Red flag. Be aware that some lymph nodes are present in virtually any child. The total absence of palpable lymph node suggests the possibility of immune deficiency, such as agammaglobulinemia. Cervical lymphadenopathy is often among the initial presentation in HIV-infected patients. Look for oral candida or gingivitis to support the diagnosis. Painless generalized lymphadenopathy may precede the other symptom of SLE by months or years. Screening for the SLE may clinch the diagnosis. Be very cautious in undertaking needle aspiration for TB lymphadenitis, as there is a real risk of fistula. Urgent referral is indicated if the lymph nodes are matted or fixed more than 2 cm in diameter, non-tender, less mobile, or associated with persistent or unexplained fever, night sweat, or anorexia, or weight loss. Fine needle aspiration has a high specificity and is less invasive, cheaper, and quicker. Kawasaki disease may present with fever and cervical lymphadenopathy only. Bacterial lymphadenitis is often diagnosed, thus delayed diagnosis and treatment can lead to serious cardiac complications. Reactive adenopathy is usually a transient response to infections of the upper respiratory tract or skin. Pharyngeal infection commonly cause cervical lymphadenopathy. Common viral agents include adenovirus, parainfluenza, influenza, rhinovirus, and enterovirus. Cytomegalovirus and Epstein-Barr virus may cause a localized or generalized lymphadenopathy, often with the hepatosplenomegaly. Bacterial causes include group A beta hemolytic streptococci, oral or oral anaerobe such as Fusobacterium. Scalp infection such as tinea capitis may cause occipital lymphadenopathy. Pharyngitis. If there is pharyngitis associated with the cervical adenitis, a throat culture or a rapid streptococcal antigen detection test may be done to help diagnose group A beta hemolytic streptococci. Viral causes include Epstein-Barr virus, herpes simplex, and enterovirus. Acute onset adenitis. Acute onset unilateral adenitis is usually bacterial in origin and may form an abscess. Bacterial infection of the skin and soft tissue like abscess, cellulitis, erysipelas, and fasciitis are primarily caused by group A beta hemolytic streptococci or Staphylococcus aureus. Subacute or chronic adenitis may be due to mycobacterial infection. Tuberculosis is increasing in incidence in children and is usually associated with the hilar adenopathy. With the lungs as the primary source of the infection, a positive tuberculin skin test and a chest X-ray may confirm diagnosis. Induration of 15 mm is considered positive in a child older than 4 years with the no risk factor. In children with the known contacts with the tuberculosis or who are clinically suspected to have tuberculosis, an immunosuppressive therapy or who have immunosuppressive condition including HIV infection in duration 5 mm is considered positive. Children at increased risk of disseminated disease or increased environmental exposure to tuberculosis are considered positive at 10 mm in duration. Interferon gamma released assay may also be used in children 5 years and older. Cervical adenitis is usually due to atypical mycobacteria, primarily Mycobacterium avium intracellulari, Mycobacterium kansasi, Mycobacterium sacrofoliolasum, Mycobacterium marium. Diagnosis is determined using acid-fast stain and culture of the excised node or by fine needle aspiration. An intermediate tuberculin skin test with 5 to 9 mm of induration suggests infection with the atypical mycobacteria. With the modern method of milk pasteurization, Mycobacterium bovis, a previously common cause of cervical adenitis, is rarely seen. Cat scratch disease, caused by a gram-negative bacillus Bartonella hensale, occurs after exposure to a scratch or bite of the cat with the development of palpable at the site of trauma, followed in 7 to 14 days of bi-regional lymphadenitis, usually axilla. Other symptoms include low-grade fever and malaise. The lymph node usually regress spontaneously within several weeks. 10% may have a purulent drainage that is culture negative. Serological tests such as indirect fluorescent antibody, enzyme-linked immunosorbent assay, IgM titer, or polymerase chain reaction test are useful in making the diagnosis. If needed, diagnosis can be confirmed by biopsy of the node showing granulomatous center necrosis and organism seen on Warthin-Starren silver stain. Kawasaki disease is determined clinically in children by noting 5 continuous days of high fever accompanied by at least 4 of the following 5 conditions: cervical lymphadenopathy, oral mucosal erythema, conjunctivitis without exudate, rash, and extremities changes such as edema and desquamation. In the absence of a known cause of these signs, the lymph node is typically single and large but not consistently present. Hodgkin disease usually occur as painless cervical or supraclavicular lymphadenopathy in older children and adolescents. Approximately 30% have systemic symptoms like fatigue, weight loss, fever, night sweat, pruritus, hemolytic anemia, and chest pain after alcohol ingestion are clues. Diagnosis is confirmed by lymph node biopsy and or bone marrow aspiration. Non-Hodgkin lymphoma usually occur as supraclavicular, cervical, or axillary lymphadenopathy. About half of children with the acute lymphoblastic leukemia present with the adenopathy at the time of diagnosis. Systemic sign and symptom: fever, malaise, weight loss, pallor, bone pain, petechial, hepatosplenomegaly may present. The complete blood count may show anemia, thrombocytopenia, leukocytosis, or leukopenia, and circulating blast cell. Acute myelogenous leukemia is less common in children but appear similarly. Several other malignancies, including disseminated neuroblastoma, rhabdomyosarcoma, and thyroid cancer, may occur as localized or generalized lymphadenopathy. Generalized lymphadenopathy may be due to infection. HIV-infected children may have systemic symptoms, failure to thrive, and evidence of opportunistic infections. Many viruses, include Epstein-Barr virus and cytomegalovirus, may cause generalized lymphadenopathy. Syphilis caused by spirochete Treponema pallidum result in both localized and generalized lymphadenopathy. In primary syphilis, there is usually localized inguinal adenopathy. In secondary syphilis, there is usually generalized lymph node involvement. Epitrochlear involvement is suggestive. Diagnostic tests include rapid plasma regain (RPR), venereal disease research laboratory (VDRL), and fluorescent treponemal antibody absorption. Toxoplasma gondii is a parasite of cat and can be acquired by humans from contact with the cat feces or by eating raw meat. Although infection may be transient to the fetus, lymphadenopathy is uncommon in the newborn and is more common in older children and young adults. Disseminated tuberculosis may present as generalized lymphadenopathy, pulmonary infiltrates, and systemic symptom. Atypical mycobacteria may cause generalized lymphadenopathy in HIV-infected children. Sinus histocytosis is a rare disorder with the massive cervical lymphadenopathy, fever, elevated erythrocyte sediment rate, leukocytosis, and hypergamma-globulinemia. It may be diagnosed using biopsy and tends to resolve spontaneously. Rosai-Dorfman disease is a form of sinus histocytosis with the massive lymphadenopathy. Drug reaction occasionally cause adenopathy. Examples include serum sickness from drugs such as cephalosporin or the drug itself. Peers and pitfalls. Persistent lymphadenopathy in patients unresponsive to treatment should be evaluated for potential malignancy. Avoid steroid use before definitive treating determining the cause of lymphadenopathy. They may mask or delay diagnosis of malignancy and exacerbate an infectious disease. The location of nodes matters. There is a high-risk malignancy with the supraclavicular node. Thank you for your listening.